Very good afternoon. Welcome. Greetings from Indian Medical Association, Academy of Medical Specialities Wing, Tamil Nadu chapter. So this is our second webinar of this year. So welcome everyone for this wonderful program. Every month we are doing the first Thursday of every month. So this is the invitations of today's program. We have all the leaders of national leaders as well as the state leaders and the today's star speakers and moderators. Welcome everyone. Very good afternoon to everyone. This is our program brief about the leaders and our today's speakers list. I'll go through in detail later. So this is the program agenda in brief. So the meeting starts with the physician prayer and IMA prayer. So likewise. So I'll do the other. Are you there? Or shall I proceed? Yeah, I'll proceed with the physician prayer. Dear Lord, though great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me a singleness of purpose, strength to lift at least a part of the burden of my suffering fellow man, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. I may prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and live. So now I welcome our IMA AMS TNSB Chairman, Dr. V. Rajesh Babu sir, for the welcome address. Dr. V. Rajesh Babu sir is a senior consultant neurosurgeon and head of the department in Ganga Hospital, Coimbatore. Dr. Rajesh Babu sir is former president of Coimbatore Indian Medical Association, currently is chairman of Organ Donation Committee as well as the IMA AMS. So over to Rajesh Babu sir for the welcome address.
Good afternoon, everyone. First of all, I welcome our state president, Dr. P. Senguttuvan sir, for joining the program. In spite of his busy schedule, he is able to join this program of our Indian Medical Association Academy of Medical Specialty AMS program. I welcome the National IMA AMS Vice Chairman Dr. Amudan sir for the program, and national leaders, the IMA President, Secretary, and IMA AMS Headquarters Chairman and Secretary for this CME, which is being conducted in the month of February. The month of February is a month where the Cancer Day is coming. So we thought of conducting the two events which are having the days in this month, the Cancer and the Sexual and Reproductive Program days. I welcome our immediate past president, Dr. K.M. Abdul Hassan sir, for joining the program. I welcome Dr. Karthik Prabhu sir, our state honorary secretary, and the state finance secretary, Dr. Gauri Shankar, and I welcome Dr. Sridhar sir, the state president-elect 2025. And I welcome the speakers of the day, Dr. Vijay Guru, and the moderator, Dr.R.Suresh Kumar, for the colorectal cancer current trends. And I welcome Dr. Priya Kannan, the speaker of the day, and Dr. Sujata Gajendran for this program. And regarding this IMA AMS, the main aim for us is this year is to increase the membership. Last year we were not able to get up to the level. We were able to get only 200 to 300 members only, the new members. And this year we are planning at least we should get at least 1,000 members. And for that we are targeting and then we will try to increase the membership. That is number one. And being a member of IMA AMS, you can actively participate in the IMA AMS activities, the CME which we are conducting every month. And some of the specialty people who are interested can conduct courses of their specialty, which the guidelines been issued by the IMA AMS headquarters, which they can follow as a guideline, and they can conduct the courses of their own. That is the one thing. So already we are having 6 courses, and this year also we are going to start 4 more courses. We are planning to conduct at least 10 courses this year totally. And also we are planning to conduct the National AMS conference also we are this year. So I invite all of the people who are all not the members of the AMS to kindly register themselves to the IMA AMS membership. So I welcome you one and all for this CME. Thank you.
I am Dr. S. Jayaraman. This is my team office bearers of IMA AMS TNSB, our chairman, Dr. V. Rajesh Babu sir, and myself, secretary, Dr. S. Jayaraman, and our joint secretary, Dr. Adar Chandil Kumar. This is our activities last month. So first month of second, there is January 2nd, we did a monthly webinar of IMA AMS. Last month, so there is a 3 commemorative day we connected. One is the cervical cancer awareness prevention and approach to polytrauma, and the current scenario of leprosy diagnosis management, with the star speakers, with the moderators, and our leaders felicitated this first IMA AMS monthly webinar. And followed by our chairman, IMA AMS, Dr. Rajesh Babu sir, released the awareness video about the Road Safety Awareness Week. So this is the video for all our members as well as the general public. And the IMA Coimbatore branch under the diabetic prevention, diabetic care committee. So we have Dr. R. Balamurugan sir, Coimbatore IMA AMS chairman and committee member, conducted the diabetes detection and awareness camp in Coimbatore Gandhi Park. A lot of beneficiaries that took part, and they did a very nice program conducted in the Panther area by our IMA AMS chairman. And Dr. Balamurugan sir from Coimbatore IMA AMS chairman conducted the CPR training camp at his hospital, become a lifesaver, and this was well appreciated by the public and other local peoples in Coimbatore. And from Chennai, in my branch of IMA Chennai Vilivakam, connected the monthly physical CME program for the commemoration of World Cancer Day and other events. So the MGM Cancer Institute participated as academic grant, and we had a wonderful topic discussion about the abnormal uterine bleeding, cervical cancer, latest drugs in breast cancer, etc. And our chairman, Rajesh Babu sir, conducted the, participated in the mental health rehabilitation. The program name is Parivardhan, and the community welfare services. So contributed to the, that is people's like mentally ill, the family, distributed the male and female go to the family members, and the chewing missions distributed for the beneficiaries. They are all for the betterment of the life. And on the January 30th, we observed the COVID Martyrs Day. So you all know very well, we had 2 major COVID waves in 2019. So our doctors, there are a lot of 2,000 plus doctors have laid down their lives during the 2 COVID waves. There are a lot of severe mortality, not only throughout the world. So as per our
slideshow.
Yeah.
Yeah, now it is visible.
Okay, right. So January 30th, we observed the COVID Martyrs Day as per our IMA instructions. Our chairman, Dr. Ramnik Bedi sir, and our honorary secretary of IMA AMS headquarters, Sairam sir, throughout the national level, all the branches of Tamil Nadu and the entire Indian continent, we observe the COVID Martyrs Day. And from the Coimbatore IMA branch, they did a lot of program from the IMA AMS activities. So last month, they conducted the road safety awareness reels contest and road safety awareness quiz program and anti-leprosy day program from the Coimbatore Indian Medical Association. So these are all the activities we are planning this month. Already started. Already our chairman clearly mentioned about our aim is to increase our membership at least 1,000 in this year. A number of branches with IMA AMS to 50 chapters. We are going to start the 50 chapters of each and individual IMA. To add 10 more courses to be conducted in the year of 2025. Already we have 7 existing courses. To create a Tom's journal this year, or at least the monthly, there is a quarterly Tom's bulletin, newsletter kind of thing we are going to release. Already last year we did. So this year we are aiming at a Tom's journal. And we are planning to conduct the National IMA AMS South Zone Conference or National IMA AMS Conference, AMSCon 2025, either Chennai or in Kadalur, Puducherry areas. We are planning to conduct the National Conference of Academy of Medical Specialty Conference and to have more people to get the FIAMS fellowship this year. And planning to conduct the 100 CMEs in this year throughout the Tamil Nadu state. And planning to conduct the hands-on training with different specialist workshop for the IMA members to create a course regarding medical legal rules for our IMA members as joint venture along with the Institute of Law Pune to conduct the zonal conferences in all 4 zones like North, East, West, and East zones. We are planning to conduct the zonal conferences. Already talk is going on. This is our fellowship course in various disciplines. So in Chennai, there are 2 courses. One is in MGM under I am the course coordinator. Regarding the sleep medicine course and Lapima-2 laparoscopy course in Chennai, we have started. So this is our application form for the laparoscopy course. Already for the past 2-3 years, this program is going on. For our members' benefit, they are fine-tuned their skills. Lapima-2024 in Coimbatore, and this is the diabetic retinopathy course, 4 months course in Coimbatore, and the infertility course. This is a 1-year course in Dr. Rao Hospital in Coimbatore. And this is the Arthima, that is an orthoplastic course, 1-year course in the Coimbatore. Regeima, that is a regenerative medicine 2024 course in Trichy, in Martyr Hospital, under the course director of Dr. Ravi. They are doing a wonderful maximum number of participants. I think 17 candidates joined in this year, already for 3-4 months over, I believe. And in Chennai, we have 2 courses. One is Lapima, laparoscopic IMA course at Chennai Bilrath Hospital, under the course director of Dr. S.M. Sivaraj sir. And in Chennai MGM Healthcare, so I am the course coordinator for this sleep med IMA, sleep medicine course, 6 months course. So under the leadership of Dr. Shivani Swami, she is National Authority of Sleep Medicine. So these are the courses already existing, 7 courses. This year we are planning to induct the 10 more courses. I request everyone, all the specialist members working in corporate hospital, either tertiary or quaternary care hospitals, please start these kind of courses for our members' benefit. So with these few, I conclude my talk. Thank you very much. May I request our IMA AMS Headquarters Chairman, Dr. Ramneet Singh Bedi sir, for the felicitation and welcome address. Felicitation. Dr. Bedi sir. Okay. May I request our IMA AMS Vice Chairman, Dr. V. Amudan sir, for the felicitation.
Am I audible, sir?
Audible, sir. Yes, sir.
Good evening, my dear friends. I sincerely thank IMA AMS Tamil Nadu chapter, which is actively doing the continuous CME programs. I'm happy to have all the 3 presidents. The present president, Dr. Singh-Seminoma, immediate past president, Dr. Abul Hassan, and president-elect for the next year, Dr. Sridhar. This session, which is a very important session, which has important topics on colorectal cancer and sexual reproduction health by experts in their own field. Now, I have one request to Dr. Jayaraman that this CME activities, the information should reach the whole India so that the AMS members from all over India can join this so that you can put the information in our AMS group, which I can forward to the headquarters group also, so that it is available to all the members throughout India so that everybody will be benefited by this very excellent organization of monthly CMEs. So this is one request which I have forwarded to Dr. Jayaraman. With these few words, I invite all the dignitaries to have their views, followed by the faculty lectures. Thank you.
Thank you, Amudan sir, for your valuable guidance. Definitely, we'll post pan-India level. Already we posted in various groups and our state national leaders and all. Definitely, I'll follow your advice, sir. So thank you. Our state immediate past president, Dr. K.M. Abul Hassan, sir, for the felicitation. Abul sir.
Okay, thank you, Dr. Jayaraman, respected president, and all the office bearers of AMS and all those also of the state office. Good afternoon to you all. IMA AMS Tamil Nadu state chapter is doing a very good job, and also, at all India level, it received so much of laurels and awards. And this year, they are going to scale up the activities as mentioned by Dr. Rajesh and Jayaraman, like starting 10 courses and also 100,000 membership this year. So my best wishes, and this CME program will be definitely helpful, and also coinciding with the Cancer Day of February 4th. This topic on colorectal cancer will definitely help our members to get some information their day-to-day practice. So I thank for this wonderful opportunity and wish the event all success. Thank you very much.
So today we are going to commemorate two important days: World Cancer Day, which falls on February 4th, and we have Sexual and Reproduction Health Awareness Day. These two events, we have two star speakers and two moderators for this discussion. So the first talk is World Cancer Day commemoration. So we have a talk on colorectal cancer, recent advances. May I request this moderator of this first talk, Dr.R.Suresh Kumar, a consultant radiation oncologist and clinical oncologist, Indian Cancer Center, Tirupur, for moderating this session. And Dr. Suresh Kumar, did
yes, sir. Good evening,
yeah.
Yes, sir.
Good
evening to all IMA members. Thanks a lot for this opportunity.
Just a minute. Please wait. I'll introduce you. Then you can take over from my
Fine,
side.
sir.
So,
Yes,
Dr. Suresh Kumar did MBBS from Madras Medical College, MD from Martyr Cancer Institute. Currently, assistant professor of Department of Radiation Oncology in Coimbatore Medical College, Hospital Coimbatore. Sir is the director and CEO at Indian Cancer Center at Tirupur, the clinical director at Bangalore Cancer Center. So achieved many laurels and special interest in brachytherapy, image-guided radiotherapy, and various disciplines of radiation oncology, cyberknife, etc. And presented many articles and papers in various national and international journals and publications. So over to Dr. Suresh Kumar and take over and start this first session on colorectal. Over to
yes, yeah, good evening, sir. Good evening, one and all. Very happy to be part of IMA, and hope we're all aware that this week we had a World Cancer Day. So the importance of cancer is coming up because the cancer cases are almost increasing. And WHO has given a projection of doubling cancer cases in a couple of years. So I think every one of our physicians should have they should be very keen on diagnosing cancers, and maybe our treatment modalities are now very much advanced in every way, and in every stages we can almost cure. We are trying for our best. So I think this presentation would throw some light on colorectal cancer, and I'm happy to introduce Dr. Vijay Gur also. He's a medical oncologist. He was there with me while we were in Adheera Cancer Institute. Now he is the HOD Department of Oncology in our ESA Medical College, Chennai. So very happy to introduce him. I think we can start over the topic. Hi Vijay, are you there?
Yes, sir.
Yeah, thank you.
Hi, sir.
Hi.
I'll share the screen.
Thank you.
I think my screen is visible.
Yes, sir.
Yes, sir.
I'm audible too.
Yes, sir.
So, good evening, one and all. Thank you, IMA. Thank you, the president. for this opportunity. I'm Dr. Vijay here. I'm basically a MD pediatrician from All India Institute, and I've done my D.M Medical Oncology from Cancer Institute, working currently in a private setup and also at ESI Chennai. So this next 20 minutes to 30 minutes, it's about colorectal cancer, which will include concepts in colon and rectum as a single entity. The untold story so far, it tries to enlighten as to what is the recent advances. Also, there are certain things which are since the past, but which is not so evident for us. So we are also trying to cover the basics of colorectal cancer, right from the symptoms, the way to diagnose, and also certain case scenarios, which are real life case scenarios. I think this session, let it be interactive. I think I have just posted chat as well. So people can try to answer in the chat box, or you can unmute, even spot out your answer. We just have to have an interactive session, not a monologue talk here. So, right, if you think if it is colorectal cancer, this is what is going to come into our brains. We have seen this in lots of movies. Marvel Studios has produced so many movies, and I think this is one of the best movies. Anything can you think about this movie and colon? I'll just give 4 or 5 seconds. If someone can answer, unmute, or feel free to talk. Let it be a wrong answer, or you can post up in the chat box as well. Any answers? So this is about Chadwick Boseman. He's a hero of Black Panther, who expired of colorectal cancer at 43 years of age. So it is not something which is unknown now with the recent increase in the number of cases, and this being one of the common cancers. This talk is because we have been in and out talking breast cancer, cervical cancer, and so on. This is one of the untouched topics, so wanted to try to bring in some highlights about this cancer. So at the end of the session, I want you to have some concepts which were actually as the misconception so far. So that is the aim of this talk. So let this not be this way. I just wanted this way, not a class though. A small interactive session which might actually keep the class going on and people get into the topics. Awareness is the first step for anything, more so for a cancer cure. So trying to be aware is the first step of any oncologist, and trying to make people aware is our primary job, and our secondary job becomes our treating of patients. I know people start reacting in different ways for each and every picture which they see. I just wanted to know how we people react. I'll try and post certain pictures. Just think, how do you react when you see such pictures? So when you see this picture, I know the next reaction might be this way. So this is a usual reaction of smoking, because in and out, right, in movie theaters, right, in all conferences, we are talking about tobacco and so on. So we know that tobacco smoking is injurious to health. It is carcinogenic, and it is going to make sure that certain population of patients are going to get cancer. But how are we going to react to this picture? We are actually not so much worried, because that is not disturbing us. So far, this is not disturbing. Now I'm trying to equate both. The first picture which you saw was a smoking, and the second picture which you saw is a happy man eating a bunch of chocolates. So this is the data which says the risk factor versus the death percentage. You can see 2 bars equal. The tobacco is equal to the diet, obesity, physical activity, lack of physical activity as a cause of cancer. So death, when it comes to death, now these 3 reasons or risk factors are trying to be equal to tobacco as a cause of cancer. Not only the cause, as a cause of cancer death as well. This data is way back in 1996. Now things are getting even more worse. We are seeing more and more non-tobacco related cancers. One among this is colorectal cancer. So this is a clear warning sign for us to step into a proper diet, physical activity, and getting rid of obesity. I'm not going to take a class on obesity. This is not that way. But then try and understand 30 minutes of exercise is going to decrease 13 cancers. We as busy doctors, we know we are worried about patients, but self-care is going to be even more important. That is going to prioritize your health, and in that way, the quality of care which you are going to give to your patients also. So this is very easy time that you can pull out of your day, though it is very casually spoken around in your social medias and all over where we see, but then the relationship to cancer is very strong now. 13 cancers have been proven to be associated with lack of exercise, poor dietary habits, and obesity. So also, this is not only going to prevent cancer. There have been studies which says exercise improves survival after overall. Yeah, we'll try to answer all the different questions at the end of the session. This is just trying to go into the topic. So exercise does improve survival even after cancer diagnosis. So if you regularly exercise, even after the diagnosis of cancer, they are going to live longer. Cancer fatigue, the cancer cachexia, the best way to, and the first treatment which we tell the people is to have a proper exercise. It adds on to the therapies, be it chemotherapy, or surgery, or radiation, whatever we talk in different new medical terms, it is being kind of compounded by this basic thing, which when gets incorporated, eases the also patients tend to kind of tolerate the medicines well. They tend to undergo the chemotherapy sessions well, and also the severity of side effect is also low among these patients. So exercise is medicine. It is a preventive medicine. It is a curative medicine. So if at the end of the class, even you don't remember anything in colon and rectum, if this basic stuff gets into the brain, and from tomorrow we start off with a very small exercise or walking, that makes the presentation and the day successful. And I know this is a very common symbol everywhere. We know this is no smoking. You know that. But what is this? Any answers? One, on account of 5, any answers? 5, 4. There are questions, but please try to give some answers in the chat box, or you can unmute. If not, I'm obviously going to tell the answer.
Sitting disease.
Sitting disease. Sitting disease. So it means sitting is the new smoking. So now that scrolling is a new smoking, so everyone is trying to connect to smoking. Now that smoking has been, the quantum of tobacco related cancers are actually on a falling trend, more so for cervical cancer, because we are trying to, tobacco is also a cause of cervical cancer. Let me clear that. So we are trying to make sure that tobacco awareness is so much into the community, though that it is not very deepened into the community level, still the awareness is high. Every other area we are trying to make sure the tobacco is injurious to health. But then we as doctors are also sitting round the clock when you are in the OPDs. Try and make sure you rise up, have some movement at least once in half an hour to at least 45 minutes. That will actually improve not only your mood, but also your long-term health. So this is something new to us. Very few questions. This is actually the question session, not into the colorectum directly still. Any idea who is this? Answers please on a count of 7, 6, 5, 4, 3. Sivamani, Vera. Anyone else? Any answers?
Alopecia due to malignancy treatment, chemotherapy.
Sir, Sir, this is a celebrity. I want the name of the celebrity. He is a celebrity.
Vikram, sir.
இல்ல விக்ரம் இல்ல சார்.
Celebrity with a cancer. Miskin
UK
கூட இல்ல, கண்ணாடி இல்ல.
ல ட்ரீட்மெண்ட்
Miskin
எடுத்தாரு.
கூட He got treated at US.
Mediastinal tumor.
As-
Mediastinal tumor.
But what is he, sir? Who is he, sir? Sorry. This is Yuvraj Singh of Singh-Seminoma lung cancer. He got treated during the World Cup 2011 and he is now still playing. So cancer is not death. So that is now almost out. Who is this? On account of
Hindi
five
actor,
again, five.
Hindi actor, sir. Hindi actor. Our father also was the actor.
Minister, Central Minister.
Answer, sir, please. The name.
In the actor.
Whoever has an Sanjay Dutt, perfectly right. This is Sanjay Dutt of lung
Sanjay Dutt.
cancer, and he is trying to survive. And who is this?
Nepal actress.
So Manisha Koirala.
Manisha Koirala.
Manisha Koirala was this way with stage 4 ovarian cancer in 2012. 10 years down the line in 2022, this is what she is. So there is a huge advancement in treatment. So many newer drugs, therapies are the picture. We are trying to improve not only the quantity of life, but also the quality of life. So this is how the momentum of cancer advancements is going on. Who is this? A Hindi actress, if someone can guess.
Sonali.
Sonali Bendre. Yeah, she was with stage 4 breast cancer, and this is herself in 2022. So these are success stories trying to portray or let you understand that stage 4 cancers are not a killer disease anymore. Not though we cannot basically translate my sentence totally into every other setting, but a bunch of patients with even stage 4 with Bendre. I know you are still waiting for the real session. This is just to awaken things. We'll go into the real topic now. Let me introduce my topic again. It is on colorectal cancers. One of the top 5 frequent cancers. Males, yes, as well as in females. So it is not something which is rare. It is one among the top 5 cancers. This is Indian data. This is in 2022, the Globacon data. In India, this is in 2022 of 14 lakh new cases every year. This is on a rising trend. By 2025, we are looking at these numbers. CAGR, the Indian cancer diagnostic market, is also on a rising trend. The value being spent on trying to find out an advanced treatment, trying to find out an advanced diagnostic technique is so much that we are trying to improve the survival of these patients. But what is actually supposed to be done is to shift this quantum of money into early diagnosis treatment and trying to screen a normal person so that you diagnose early. That reduces the cost, the burden, the country's burden as well. What is expected? India is one of the medium human development index country. So this is what is expected in 2040 across all human development indices. In medium HDIs, that is one among that is India, you are expecting 70% rise in the annual number of deaths in million. So that is going to be the projected number. So these are fear factors, alarming factors. So this is how we have come together, united by unique. This is our new theme of World Cancer Day on 4th February. You by you, united by unique. Let's not try to generalize protocols or treatment like colon cancer, stage 3. This is the chemotherapy for all. That is not the way anymore. Even we talk on something called as personalized medicine, means every other genetic problem is now targeted. Now we are advancing from that. We are not confined to only the theoretical aspects of cancer. We are getting into the patient level. That is what is trying to be projected in this World Cancer Day, that is United by Unit. Means this is the blue ribbon of colorectal cancer awareness. So this is supposed to be a people-centered approach to cancer care. So every patient is going to be different. A stage 2 cancer of colon between two patients of same age, same BMI, both are going to behave differently, even if their genetics are same. So every patient is supposed to be looked into their problems, their stagings, their molecular problems, and each one needs an personalized approach when it comes to cancer care. What is it going to do? It is going to get things more compassionate, because each patient's experience is different in need, preference, and circumstance. So the focus is not on treatment, but also a holistic healing. This is going to improve, one, the patient outcomes in terms of survival and also the quality of life. So we have come a long way from the first chemotherapy, that is methotrexate by Ellapragada Subbarao, who was a person from Andhra who was never recognized for his all his discoveries. He was the one who kind of discovered ATP, the DTC of filariasis, and also the first chemotherapeutic medicine, methotrexate, which then made the breakthrough and is still holding on as a main drug in most of the cancers and non-cancerous conditions as well. So into few case scenarios, I'll try and do something on this recent topics. So here is a 70-year-old female with cancer rectum who presented to us with a bleeding per rectum. It was locally advanced. It means that it is not operable at the beginning of the treatment. The patient wanted surgery, but then we told her that it is not operable at the beginning of the treatment, and it is lower down in the rectum, very close to the anal canal. It is again adenocarcinoma, so it is not an anal cancer. It is a proper rectal cancer, adenocarcinoma, which is in an inoperable stage, which might require some form of therapy before operation. So the patient is asking the doctor as to what is the treatment plan. Doctor is trying to explain that the patient needs chemotherapy, radiation, followed by surgery. At 70 years, this patient is worried how is she going to tolerate so many things. And her next question, it is not kind of confined to an age group. Every other patient asks, the first question is, are you going to remove the tumor alone, or are you going to do something different? Because it is in the low down of the rectum, this was our treatment plan to do an APR. It means a proper perineal resection means you will remove the tumor and do a colostomy, which is going to be a permanent colostomy. So we are going to do a permanent colostomy to remove the tumor in toto. So the most common problem or an inhibiting factor from the patient is when you start talking on permanent colostomy. For any obstruction of tumors which are higher above, we do a colostomy for diversion initially, and after treatment, we kind of reconnect. But then when it comes to a rectal cancer lower down, the problem is you cannot kind of save the sphincter. So sphincter saving surgeries are difficult. Henceforth, we will have to do a proper APR and get a permanent colostomy done. When the patient hears such terms, what is next? This is how her reaction was, and she defaulted. So this is a very common scenario few years back. But do we have any questions or answers now? Do we have really non-surgical techniques? Is it safe, and who can all be offered the same? When it comes to colon and rectum, everyone is like, yeah, good, get a surgery done. That is going to be the best and the curative treatment. Now we are going to see something which is non-surgical. Is it really possible? Is it really safe? Few months ago, there was a huge noise around this. Cancer in all patient vanishes for the first time during a US drug trial. And Tamil 100% குணப்படுத்தும் மருத்துவ வரலாற்றில் புது மைல்கல். This was a drug which was taken off temporarily, that is dostarlimab. It is an immunotherapeutic agent. What was the so much hype behind this? At that point of time, they had done a trial which included just 12 patients, and then they gave this drug without surgery, no radiation, no chemotherapy. They just diagnosed the patients with rectal cancer. They gave this medicine, and they saw all went into complete remission. The tumors vanished. Is it really good? We, as oncologists, were also initially surprised, but then we were very sure that at some point of the time, the patient will relapse. And how is the pharma or the trial walas going to tackle that problem? But this is 2024 update. Still, you see 100% clinical complete response rate in 42 patients who has completed treatment with dostarlimab. It means it has done its job in all the patients who were expected out of this in the initial period, and it is holding true even after 2 years of follow-up. Is it going to be for everyone? This is an immunotherapy which is trying to make sure the chemotherapy is basically trying to kill the cancer cell. Immunotherapy is trying to boost your immune system, and the immune system is going to tackle your cancer. It is supposed to be used in rectal cancers, locally advanced, and a specific subtype of rectal cancer, which is called MSI high subtype. So not for all rectal cancers, not for all patients with a locally advanced one. This tunes to around 5% of patients. So if you have 100 patients with rectal cancers, around 5 to 10 will have this subtype called MSI high subtype. Just like we call in your histology, adenocarcinoma, squamous cell carcinoma. So those are histological differences. Now we are coming to the molecular stuff, and this is called microsatellite instability high subtype. This is a specific subtype which is giving the advantage of getting a complete response with immunotherapy. And this is a phase 2 trial. As we know, phase 3 trial is better enough, but I don't know whether at all they will do a phase 3 trial, because to compare two ones, when we already know that a drug is doing wonders, we will not want to compare with another drug which is actually not going to touch even this a lower bar of this trial. So this is really a milestone, and now all the guidelines across the world has changed. We are not offering for everyone chemo, radiation, and surgery. We are trying to kind of classify from the beginning as to what subtype they are and treat according to their subtype. This is improving survival. This is improving quality of life. It is also improving the long-term overall survival. This is a second scenario. Now, little in deep into the concepts of oncology. So here is a 65-year-old female diabetic hypertensive who got evaluated for constipation and bleeding rectum. Examination had a pallor, had a circumferential growth on the left side of the colon, that is on a descending colon, with regional adenopathy, and had an adenocarcinoma on biopsy. Henceforth, she went a left hemicolectomy, and post-operative histopathology showed a stage 3 colon cancer. So as a medical oncologist, post-surgery, when we kind of start our OPD with such patients, what will be the scenario? So this is the doctor, here is our patient. So we don't really feel sorry for they having cancer. It is not a mistake of the patient. So this is just a small example of that. So I'm sorry you have a stage 3 cancer from the doctor. Yeah, but you have cured because it is taken out. This is the answer from any patient, be it breast cancer, colon cancer. If a surgeon takes off the tumor, the patient is extremely happy that the treatment is over. We are also happy that a major part of the treatment is over, but it does not complete the treatment. Do not think cancer as a tumor, though the term tumor is still a very vague term, because there's not a swelling there. It is a disease That is why we are trying to make sure the survival is improved by systemic therapy, because local therapies try to improve a local control in terms of local recurrence. The disability in the local area is taken care by advancements in your local therapy. A good surgery, initially a radical mastectomy, then came the modified radical mastectomy, then now breast conservation surgeries. Everything is trying to improve upon only the quality of the organ preservation. The systemic therapy is trying to improve upon survival, means that it tells us that it is just not a swelling which is present in one part of the body. This is a disease which has actually spread, which is not seen through your naked eyes, even during surgeries or through your scans. So none of these are giving information as to what is the minimal metastatic or the micrometastatic disease of the patient. So this patient was counseled for chemotherapy to prevent a recurrence. So this patient, as most of our patients will tell, will go back, discuss and get back to you. Gets back to home, gets into so much thought process as to whether it is cured or not. 2 years, patient comes back with a scan showing disease again. So always it is a team board decision. It is not a medical oncologist or a surgical or a radiation oncologist in isolation is supposed to treat a patient. A proper onco care is supposed to have a medical oncologist, a surgical oncologist, and a radiation oncologist trained in their respective fields in a better way, trying to meet the patient's requirement. This is all about U by U or United by Unique. That is the new theme of 2025 World Cancer Day. And this is all about so many stories and interactions. Very short on what actually is colorectal cancer. So it is going to be from the colon or the rectum. Can be a polypus form or a non-cancerous ulcerative form. Either of these two can be cancers. As a normal polyp can also be cancer, gradually develop dysplasia and then become an invasive cancer. So do not just neglect a polyp also. Polyps come in different shapes. So a gastroenterologist will be doing the colonoscopies and trying to describe the polyp. So trying to make sure if they are dealing with the malignant looking polyp or not is the prime first question which a gastroenterologist is going to ask himself or herself. Some polyps may be even very hard to see. So these are usually the presentations. You have non-modifiable risk factors. I'll come to the question of veg and non-veg very shortly. So as we age, it is about as a risk factor for cancer. As you know, every other cell is going to have its own death and kind of again a mitosis. Every thing is having a fidelity of it itself. So any small error in the DNA replication will introduce a cancerous cell. Family history in colorectal cancer, close to 10 to 20% can have some form of family history. Inflammatory bowel disease patients. What are modifiable risk factors? Obviously, this junking is going to make alcohol smoking, red meat in excessive quantities or harmful, not meat as a single factor. A properly cooked occasional intake of meat is not carcinogenic. So far, what has been proven as a carcinogenic is only the frequent intake of ultra processed or improperly cooked red meat and lack of fiber. So these are not only for metabolic diseases. Now cancer will enter into one of the, though it is one of the non-communicable diseases, it is supposed to be a metabolic disease as well. So there are so many mutations which can happen in the polyps, which is actually making a polyp or a normal epithelium to get into the cancerous cell. They can present with change in bowel habits, blood in stools, unexplained weight loss, persistent abdominal discomfort. So do not neglect any single symptom. That is a problem. We tend to think as doctors also that it might be a fissure, it might be a hemorrhoid. Try to postpone the symptoms. That is one of the major mistakes that and one of the reasons for us getting the major proportion of your patients in the advanced stage. So though you could have got a screening done, though you everything is in favor of you, but do not neglect a small alarming symptom. Get a proper diagnosis done. As every other diagnosis of medical community starts with the proper physical examination, digital rectal examination, a scopy, the biopsy, and other organ function tests. So scopy and biopsy is essential before we conclude and utter a word of cancer to the patient. A small note so far, what is again different in the recent years? Right-sided colon is different from left-sided colon when it comes to cancer. Why? We'll look into that. Right-sided colon cancers are more common in women. Left-sided colon cancers are more common in men. When it comes to the molecular type, there are different set of molecular entities for right colon cancers and different set for the left-sided colon cancers. More of fat and carbohydrate related problems on the right side, lack of calcium and other problems, meat and stuff as a reason for the left side. Right side presenting with loss of weight, left side presenting with obstructive symptoms. These are easily remembered symptoms, but remember, right side colon is from the midgut and left side colon is from the hindgut. So the embryology is different. And even when you're thinking from a medical oncology perspective, right colon is different from left colon. Each and every mutation which is supposed to be in a colon cancer also differs between right and left. So here is another 50-year-old gentleman with no comorbids, pain abdomen, loss of weight for 3 months, very normal on examination, has a mass in cecum with liver metastasis. This is actually a very common scenario. People might come with only loss of weight, no GI symptoms, no bleeding, no abdominal pain, no obstructive symptoms, more so for your right-sided colon CS, which might actually come up with a metastatic disease. Again, biopsy suggestive of adenocarcinoma. This is in April 2020. Treated with chemotherapy and a properly designed targeted therapy, but the patient progressed and expired in August 2021. So even after the best and best of treatments, the patient has given we have given them patient possibly 1.5 years of survival. So mass in cecum, liver mets, right-sided colon cancer. Sorry, sir. So progressed and expired in August 2021. But, and this is another scenario of a similar age person with even so many comorbids, constipation, loss of appetite, loss of weight, again, CT showing a growth in the descending colon, nodal mets, multiple liver mets, multiple lung mets, as opposed to the previous patient who got only liver mets, a right-sided colon CA. This is a left-sided colon CA with multi-metastatic disease. Same time, April 2020, adenocarcinoma, properly treated with chemo and targeted therapy. Left-sided colon cancer, doing well, even on the last visit in May 2022. After that, the patient actually progressed and expired. But there are patients who are, one lady is going on from 2020, even till now, a left-sided colon cancer with multiple lines of different types of chemotherapy, still going on with a better performance status, good quality of life, and also surviving to her extent. So right is different from left when it comes to a medical oncologist. It differs in terms of embryological origin, blood supply, and so many biological differences. It is midgut versus hindgut. Arterial supply is different. There are biological differences. Primary bile acid is more on the right colon, which is carcinogenic. Right colon has more biofilm on, as opposed to their left-sided colon. And a right side of colon ages faster than the left side colon. So right side colon is, so colon as a single entity cannot be taken in total. So now the branch of medical oncology is trying to get into the depths of every other aspect, right from embryology to the biological differences and even the aging of each and every organ. There is molecular heterogeneity also of right versus left. So this is how a colon cancer is supposed to be looked at. A difference in terms of sidedness, difference in terms of staging, difference in terms of treatment as of now. But still, most of our patients present at an advanced stage. We have options of surgery, radiation therapy, chemo, and targeted therapy. From the age-old medicine of 5FU, which is still holding true, which actually destroys your RNAs and DNAs. We have a list of chemotherapy drugs, we have a list of targeted therapies, a proper diagnosis, trying to understand the patient's disease biology, their performance status, what does the family expect out of the treatment, and what is the patient's long-term goal. Every aspect is to be taken into account before we decide on what treatment we are going to design. So every other molecule has a target now. So it has gone into the cellular level, trying to find every protein, trying to target that. And this is an old picture. There are pictures which show so many number of new therapies, and so many are in the pipeline. We are edging far in terms of metastatic colon cancer treatment, yet the awareness is less. So it is not more impossible. Here is a 45-year-old healthy, exercising daily, no family history of cancer, but has bleeding per rectum. This cannot be cancer. Is it true? If you are still not convinced, be ready for the battle. This is going to be a really tough battle. So it is not as easy as we see it on a theoretical paper or every patient who undergoes. It is not confined to only the patient. The family undergoes in terms of the treatment, the social, the financial, every aspect is getting to be involved when it comes to cancer treatment. That is why it is supposed to be a holistic approach from this new U by U. So cancer is curable if detected early and treated properly. Appropriate regimen, correct sequencing will improve survival, improve the quality of life in advanced cancers. So let us fight cancer together. To summarize, early diagnosis is the key. Newer advancements gives more cure, less toxicity, survival, quality of life, both are equally important. Molecular field is rapidly growing. Encourage screening among your family. Stay healthy, but still get screened. You never know how strong you are until being strong is the only choice you have, which is for the patients. Thank you.
Yeah, it's very well done, Dr. Vijay. I think you have added every gone into all scenarios in colorectal cancer, and I think you can make a mention about the staging, screening when we need to get the colonoscopy done, and I can also answer the questions in the chat.
You take up the screening section. Should I or you? Any questions? Stored food like 2 to 3 days, home cooked itself, in a long run can it cause cancer? None of these have been proven. The problem is we cannot try and find out which patient had a long cooked food. So practically it is not possible for us to do a scientific study to find if a stored food is going to cause cancer or not. So that is practically impossible. But then we know every storage is going to give you but we know a list of carcinogens, and we know which the stored foods on a longer term are going to have some carcinogenic material developing in that. So that is an indirect answer to tell, yes, fresh cooked foods. Make sure your protein intake is good, your fiber intake is good, your gut is healthy. Gut health is going to make sure every other aspect of your life being taken care of. Primary care physicians.
Regarding diet, vegetarian and non-vegetarian, which people are more prone to get colonic cancer, sir? Is there any high risk group? That is, if you take a non-veg more, you may develop the
if so, Adam and Eve should have started. So that is not as simple as it. The problem is This is a misconception at our medical community as well as to easily tell that the non-veg is bad or it is carcinogenic and veg is non-carcinogenic. Not that way. A French fry, which is a vegetarian, is going to be carcinogenic. A patty or a burger which has a vegetarian stuff in it is going to be carcinogenic. So it is not about vegetarian or non-vegetarian. It is not easy to box it into two letters. Any ultra processed, preserved foods on a long term is going to be harmful. We know they are having substances which can be carcinogenic. So IARC or the cancer research groups will try and define the carcinogenic agents alone. They will not find out the food. So if you like tobacco, we don't tell 555 cigarette or BD is harmful. We don't compare both. We know that the tobacco inside that is bad. So we know what are the carcinogens, and any stuff which has a carcinogen in it is going to be carcinogenic. Answering to your question directly, non-vegetarian food, if very frequent, improperly cooked, more of a red meat consumption, very often grilled foods, very often too much oiled, fried stuff has been shown to have associated with this. But on the whole, such food habits have also been associated with lower fiber intake, with obesity and lack of physical activity. So we cannot actually blame the food alone. For that matter, you can see all your army people taking so much non-vegetarian, they are healthy, fit stuff. So every other aspect of your lifestyle is going to make an add-on cost to the in total problem of cancer.
Sir, which country food is safe or unsafe? Which country food to be followed?
We have
They say American food favors colonic CA. There is a thought. So, like your comment.
So, American food is very good in America. Indian food is very good in India. We have so many things like turmeric proven to be anti-carcinogenic. We have a properly conducted trial saying sambar is good, right? Doesn't mean that you keep taking sambar and you will not get colon cancer. Or we cannot tell we do our RCT, people with sambar, people without sambar, who is getting. So that is in trial wise not possible. We know there are good substances. As we know there are bad substances, we also know the good substances which are helpful, which increases your immunity, which increases your omega fatty acids, which reduces your reactive oxygen damage. So we know the components which will actually help in these ways. So the foodstuffs which have all these components, one such example is sambar, which, because it has already been proven, I'm trying to highlight that, that is giving a better being out of your cancer colon.
A few words about cancer screening for primary care physicians, please.
Cancer screening, let me not confine to colorectum now. Not to kind of impress anyone. I know I'm also getting into 40s. Most of us are under 40s. How many of us have got screening? Thinking that we are getting screening for a possible no cancer. Yes. So I presume that a few of us would have got screened. Most of us have still not. So once we start getting awareness into us and try all this, I think our translation to the patient level is also going to be better. So coming to the point again, screening is in two broad headings. For patients with, sorry, not patient, for persons with average risk, for persons with high risk. High risk group is easily defined. If a relative has a breast cancer, first degree relative get it screened at an early age. First degree relative has a colon cancer, get it at an early age. Someone has a familial adenomatous polyposis, gets an early screening. But when it comes to the average risk, there is no low risk. There is an average risk or high risk. All those without a risk factor. like people without a family member with cancer, who are really healthy, who have not had a cancer in the past of any other organ, will fall into average risk. Now, what do we have for such persons? I'll try to explain one by one. I'll just take 2 minutes. One, getting screened at 40 years of age and above is safe. We do not have a correct cutoff point to end when we should screen. Every other screening program try to extend based on the possible longevity of the patient. Like some stop at 75 years, but very healthy persons after 75 years. I have a 92-year-old with a head and neck cancer. He is a healthy walking male into the OPD. I cannot say no treatment to him just because he is 92. So age is getting age as a factor is now getting apart. It is all about how fragile or fit is the patient, leaving apart age. So back to the topic again. So screening can start as early as 40 years of age. If you have high risk persons in the family, or if the person whom you are screening per se has a high risk feature in terms of, I'll just take an example of breast cancer. Someone with an unmarried or a late married, early menarche, more estrogen stuff is there. Then trying and doing a calculation of how bad is the risk, and then trying to tell them that they are into the high risk and getting a screening done at an early age is safe. For all our easy understanding, just take 40 years as a cutoff to start off our screening. Now that is about age. So second question is what to screen. No one will know what cancer, when is it going to come. And we don't know as whether at all you get a screening and that is going to be safe if it is turning out to be negative. So there are two things to this. One, staying healthy is the first important thing. In spite of that, getting screened is the second important thing. I'll tell you the third important thing the next way. So getting screened, there are different schedules for each and every organ. Breast for females, annual mammogram. For colon, 5-yearly one sigmoidoscopy or once in 10 years colonoscopy. Now, someone with a family member having a colon CA, 6 years once of colonoscopy. So every other investigation has a different frequency of getting it done. This is about imaging. Coming to the tumor markers as screening modality, though we think if you find one and you see it is high, we go and do testings, but that might be counterproductive. If it is normal, you do not test a symptom, that is again bad. You leave a localized cancer to spread. So tumor markers as a modality can be useful, but that as in isolation, you cannot depend only on tumor markers for you to get screening as a modality. Third thing, we got a screening done at 2024. Next screening is in 2025 December to December. Someone who develops a symptom midway tend to think, I just got screened, I did not have cancer, so why do I fear of cancer now? Let me delay the symptom. So the third thing which I wanted to tell is, the first thing is stay healthy, get screened, do not neglect a symptom. So that is more important. Not that every symptom has to go to an oncologist. A primary care physician giving importance to every symptom, trying to make sure they are not missing out something which is bizarre in there, will actually try to pick up early stage cancers. So these three things are important when it comes to screening.
Sir, any alternative for colostomy, sir?
If a patient has a low rectal cancer and it is adenocarcinoma, still localized, not spread, and no other molecular stuff is there, colostomy equal to cure. So the problem is we tend to kind of have a stigma for colostomy. So the aim is to remove the stigma behind colostomy rather than to kind of find out non-colostomy ways of treatment.
Role of probiotics in cancer, sir. Do they have any role?
When they develop diarrhea, we give. Otherwise, no role in cancer.
Thank you very much, Dr. Vijay, for the wonderful talk. So crisp and clarity. We have, there are 5 case scenarios, lot of movie, examples of cancer, completely curable disease if you detect early. A lot of take-home points. Thank you very much, Vijay, for the wonderful talk. Thank you for the wonderful moderations and question answers. So thank you all. So any questions you can address later. We'll move on to the next topic of discussions. We have sexual and reproduction. Sexual and reproduction health awareness day talk. May I request there are two stalwarts here. One is the Dr. Sujata ma'am. Dr. Sujata is a senior consultant, senior obstetrician and gynecologist, and is director of a wellness women clinic, Mohapir, and specialized in high-risk obstetrics and infertility. Ma'am is a visiting consultant in Apollo, SIMS Hospital, Healthcare, Kaveri Hospital, Prasad Mehta Hospital. Madam has received the prestigious Lifesaver Award from the Rotary Club of Chennai Medical Fraternity. Mayan Award, this international prestigious award for the professional. And Madam received the IMA Women Doctors Wing Appreciation Certificate 2021-22. Madam has given a lot of awareness talks on women's health and preventive gynecology in various schools, colleges, webinars, health camps, and social media. Presented many articles and papers in various national and international journals and publications. So with that few intro, may I request Sujata ma'am to take over and start the session on sexual and reproduction health awareness talk. Kindly introduce the topic and the speaker of the day. Over to Sujata ma'am.
Good afternoon, everyone. I thank our dynamic secretary, Dr. Jayaraman sir, our chairperson, Dr. Rajesh Babu sir, our co-secretary, Dr. Ada Sendil Kumar sir, for this opportunity, and the organizing committee for me to moderate this session on sexual and reproductive health. It's a very unique topic, not much discussed, but it is very important because sexual and reproductive health includes both physical, mental, and social well-being of a person so that they will have a healthy body. So backed by the WHO, we have a human reproduction program for the past 50 years. They have a set of guidelines for sexual and reproductive health rights, which sets the guidelines for fertility control, for contraception, for antenatal, intrapartum, postpartum care, and also for the prevention of transmission of diseases from mother to the child. So it's very important we have this topic, and I feel the organizing chair and more because of the Sexual and Reproductive Health Awareness Month, this topic is more for the current generation because most of them, our younger generation, are into career growth. So they have late marriages and delayed childbirth. So when they have a good sexual health only, they can go into a proper reproductive health. சுவர் இருந்தாதான் சித்திரம் வரைய முடியும். So sexual health நல்லா இருந்தாதான் when they plan for their progeny, the reproductive health will be good. On this note, I invite Dr. Priya Kannan, who's a well-known embryologist and director of Garbha Rakshambigai Fertility Center, and who currently holds many prestigious posts like Secretary Tamil Nadu Chapter IFS, Secretary IMA Chennai Kodambakam, and Chennai District Coordinator IMA NHB. And she has contributed in various chapters and textbooks and been very much resource person for the national and international conferences and co-investigator in the first trimester RPL and also in association with exogenous DNA with mammalian spermatozoa. She her past positions as like past president of Academy of Clinical Embryologists of India 2018 and 19, organizing chair for the 8th International Conference of Academy of Clinical Embryologists, and EC member of ISAR. And more importantly, she is the daughter of our famous and well-renowned senior obstetrician and a fertility specialist, Dr. Jayam Kannan, who needs no introduction. So over to you, Dr. Priya, to enlighten us on sexual and reproductive health. Thank you.
Thank you, madam. Thank you for those kind words of introduction. I hope to live up to the legacy, though it's extremely difficult. It's proving to be extremely difficult. I try, but I'd be happy if I'm at least 10% of what my mother has achieved. Thank you so much for those kind words, madam. And I would also like to thank Jayaraman sir for giving me this opportunity to be in this very prestigious forum. Can you please share my slides?
Our National IMA AMS Headquarters Secretary, sir, Dr. Sairam, sir, for joining this CME, sir. Welcome you, sir.
Sir, Sairam, sir.
Sairam, sir.
Thank you very much.
Sir, you can give your felicitation, sir.
Yeah, I'm very happy that Tamil Nadu chapter is doing very good CMEs. I actually had joined headquarters and then I had to come again here. So, colorectal cancers are the commonest cancers in the developed countries, but we are also getting a lot of colorectal cancers. So, it was an apt topic. Now we'll go and listen to sexual medicine, because we are also starting andrology and sex medicine fellowship course shortly. So we would be having first-hand information about andrology and sex medicine. So I'm very keen to learn from the speaker about this andrology and sex medicine. Thank you. Thank you for inviting me and allowing me to express my feelings. Thank you.
Thank you, sir. Thank you.
Yes, madam, you can continue.
Thank you, sir. Thank the organizers, and especially Jayaraman sir and the entire team of AMS Tamil Nadu for giving me this opportunity. And today we would be speaking about reproductive health, which also encompasses sexual health. So it is the reproductive health, and that is where it starts. I thought my time was just limited to about half an hour, so I have abridged the entire WHO definition and the expansion of reproductive health. So I'll be highlighting only a few features today, but of course, as sir has said, sexual health with andrology is a major subject for us, but however, it is starting to gain a lot of importance with a lot of urologists taking into reproductive urology, and we are very happy to have them take this very important subject for men of the present age. As Sujata ma'am has already mentioned, reproductive health is not just getting babies. It is a state of physical, mental, and social well-being in all matters relating to reproductive system. It refers to diseases, disorders, and conditions that affect the functioning of male and female reproductive systems during all the stages of life. In 2008, WHO assessed that reproductive and sexual ill health accounts to about 20% of the global burden of ill health for women and 14% for men. And according to the United Nations Population Fund, the unmet needs for sexual and reproductive health deprive women of their right to make crucial choices about their own bodies and future, which directly affects the family welfare. When we take a life cycle approach to reproductive health, it should not be merely confined to the health of the individual at the age of when she or he is capable of reproduction, but it should be recognized that it extends along the entire life from infancy to old age, because the health of an infant is largely dependent on the mother's health status and access to healthcare during pregnancy, childbirth, and the immediate postpartum period. All these topics or all these headings or all these also are part of the reproductive health, starting from contraception, menstrual disorders, infertility, maternal child health, cancers, sexual problems, sexual violence, sexually transmitted diseases, and mental health. All these encompass reproductive health. Unfortunately, since we don't have the time for the entire thing, which is a whole, probably a conference on its own, I'll be concentrating on a few important aspects. And to start all this is also important to not just look at age between 23 and 45. it is important to look at adolescent reproductive health as well, which is a state of complete physical, mental, and social well-being, not merely to the absence of disease or infirmity. It also matters relating to the reproductive system of people between the age of 10 and 19. So why should we talk about adolescent here? Because 1/5 of the world's population are adolescents, and 85% of them apparently are living in developing countries. And in our country, about 23% of our population are adolescents. So there was a stat which said that 9 out of the 10 adolescent girls in Delhi are anemic, and 90% of Delhi University girls who volunteered for blood donation were rejected because their hemoglobin was less than 12.5 gram percent. There is a program by Federation of OB-GYN Societies of India that at the age of 12, all girls must have 12 grams hemoglobin. It has been there, not just now, it has been there for at least 8-9 years now, and it is a continuing program with the help of a lot of doctors and hospitals that we continuously keep striving to test girls for hemoglobin, and if they are found to be deficient, to give them iron and every support that is required. And for them, in terms of mental well-being, it has been said that out of every 3 cases of suicide reported, 15 minutes, every suicide case reported every 15 minutes in India, one is committed by a youth in the age of 15 to 29 belong to our South India, which is very strange and very shocking for us because we feel we'll be having a good quality of life. And especially in the Union Territory of Pondi, every month at least apparently 15 youth between the age of 15 and 20 and 25 commit suicide. This study was conducted by CMC on teenagers in Tamil Nadu, especially in the Vellore region, found that the average suicide rate for girls is as high as 148 per 100,000 and 58 per 100,000 for boys. The mental well-being of adolescent in the age group of 10 to 19 and even up to the age of 25 is extremely important for us. And when it comes to the health, and we also heard about obesity and cancer. Obesity, I think, is related to almost everything right now. In short, we can say that the adolescents of urban India and urban slums and even in the upper strata are obese, and adolescents of the rural India are somewhat undernourished. So that is something that we should have in mind when we are talking about the entirety of health of adolescents in our country. As we see, this is how the obesity goes from as we go from childhood to adolescent, and overweight kids become overweight adults, leading to a lot of problems, including metabolic syndrome, which also starts from cancer to lipid problems to diabetes, hypertension, dementia, cancer, and of course the PCOS and non-alcoholic fatty liver syndrome. And the reproductive health in the adolescent has been correlated to unhealthy lifestyle and early marriage, unwanted pregnancies, complication of teen pregnancies, morbidity and mortality due to early pregnancies with RTIs and STDs. We might be thinking, why complication of teen pregnancy in our country? Apparently, there was a study which was recently published which said that there has been an increase in teenage pregnancies in Tamil Nadu, and with, I think it was Dharmaburi, which had the maximum number of, which had the highest in that population. So it is not something that we thought it's going down, and there is a resurgence of teen pregnancies right now in Tamil Nadu as well. Having said about the general health, the next most important thing that we would like to talk about in reproductive health when it comes to females is menstrual problems. More so, having said that, it could be categorized into amenorrhea, oligomenorrhea, or menorrhagia. All of this has been seen in our girls in the entirety of the reproductive age. The most common being the hormonal imbalance to lifestyle disorders. And let us say, be more specific to say about PCOS, thyroid disorders, eating disorders to certain contraceptive and also endometriosis. There is usually what we see, excuse me for my voice, I have slight amount of upper respiratory infection, so I am recovering, but sometimes the voice just gives away. There are a lot of things that are happening right now. Pregnancy is one. We are seeing quite an increase in the premature or very early menopause right now, or early diminishing of ovarian reserve, which we are seeing quite often in our practice right now, not just in mine, even in general gynec. We see that the AMH is quite less even in the in 20s and early 30s, which was not the case before. We are unsure of what could be the reason, but that is a trend that we are seeing. And more so about the stress, there is weight loss and excessive weight gain and sedentary lifestyle, and as opposed to non-use of a lot of contraception. And PCOS is something that we are seeing very often right now. And the prevalence of PCOD has been measured to be somewhere around 30 to 40% of our girls, according to the Indian Journal of Pediatrics. And it occurs, it is expected, it's been told to occur in 1 in 5 girls and young women in India. And the risk of glucose intolerance among these women is 5 to 10-fold higher than normal. And about 30 to 40% of these patients with PCOS we have seen and has been documented to have impaired glucose tolerance. And about 50 to 60% of them are also obese. We do have 2 types of PCOS. One is the obese PCOS, the other one is the thin PCOS. And more so in our country, we see a lot more of obese PCOS than the thin PCOS. And the first line of control or the treatment for PCOS is the lifestyle changes. Especially it's been there since 1998 that when obese PCOS, they reduce their weight by 10 to 15%, then their ovulation is back. And so they are able to have regularized their periods and even have a fertility rate which can be equivalent to the general population. This lifestyle change has to be both diet and exercise, because we definitely need to work the tertiary glucose receptors. And yes, the image right now when people have PCOS is we will not be able to get pregnant, which is a myth. Yes, they can get pregnant. And to be very frank, not all PCOS do need to go through IVF to get pregnant. Just with regularization of the menses by diet and exercise, and probably with the help of some insulin sensitizers, they can also have pregnancy by spontaneous conceptions also, which has been shown not just now. One of the earlier path-breaking or a prize-winning paper by, let's say, 30 years ago in Brazil was from another author over the world, where they gave ovulation induction for a PCOS for 42 days, after which she had a spontaneous conception, which was 30 years ago, and it still holds good. We just have to be patient. The patient also has to be patient for the same. And the next important aspect is infertility, which we seem to be raising right now. It is not just a gut feeling that we are all having. It is also a publication from the WHO. Earlier, we used to say 1 in 8 couple would be affected by infertility. Now it has increased to 1 in every 6 people globally is affected by infertility, which is a report which came around about a year and a half ago, which also emphasized the need for accessible and high quality fertility care for those in need, which again brings us to the point that most of the fertility care right now is out of pocket expenses, this emphasizes the point of including infertility also as part of the insurance, because it is not something which is very uncommon. It is becoming to be very common. In terms of India, where we think we are the most populous country in the world, but still, even in our country, every 1 in 6 couple would have infertility. And we do face a huge burden of infertility with 22 to 33 million couple in the reproductive age suffering from infertility. And assuming that the marital rate in 2020 is similar to the one which was earlier, the number of infertile couples would have increased from 2015 to 2020, from 220 million to 244 million by then. I'm sure by 2025, when we would have a newer study, we could have a lot more given the increase in the sedentary lifestyle, increase in obesity, increase in metabolic syndromes, everything put together, and the trend that we are seeing now with reduced ovarian reserve at early ages. So I'm sure it has increased. So it is time that we all are adept to the idea that infertility is not a foreign problem to us. It's an inherent problem in our society as well. And it is not a disease, it's a symptom. We have diseases which cause this, such as PCOS or endometriosis or male infertility, which is a major thing. And the treatment is not always infertility. About 70 to 80% of the cases at least can be treated, and they can have a live birth rate with conventional medical therapies. In this, a word about the female sexual dysfunction and the male sexual dysfunction. They encompass about 10 to 15% of the problems we see in our clinic in infertility, more so with the male because of the anxiety. The stress-induced erectile dysfunction seems to be on the rise, and especially when we say about the fertile period, we suggest that they have intercourse at least every alternate days. Now, men find it difficult to conform to that thing, even during those days, especially during those days, because of the stress-induced erectile dysfunction. It's quite a lot. And as we all know, the moment we see there is an ED, we also look at glucose. In that case, sexual and sexual problems is a major thing. It encompasses about 10 to 15% of our reason for infertility right now. And another major reason for infertility right now is the logistic issue between the husband and wife as well, which also needs to be addressed at some point, which leads to a lot of stress among the couple. The cause of infertility, as we know, 40% is approximately male and 40% is female, and about 20% is unexplained infertility or multiple factors as well. When we say IVF, this is what everybody thinks, test tube baby, but unfortunately that's not the case. The lab is this. It's not, they are not in the test tubes. Nowadays, they are in the Petri dishes. So where we have drops and then we put eggs into it, and then we put about 150,000 sperms calculated around each egg. And that's how conventional IVF happens. When it goes through, why IVF is stressful? Because it involves a daily injection for the female partner on a daily basis. Even if it is because of pure male infertility, if it is a zoospermia or anything, it is the lady who takes the brunt of daily injections. And that's the number of injections. Probably she takes one every day. And we do the egg pickup where we aspirate the eggs from the follicle. And then that's how this is how you see the cumulus oophorus complex under the dissecting microscope. And we do conventional IVF where we put about 150,000 to 200 sperms around each egg. Whereas in terms of male infertility, conventional IVF cannot be done because you need that much number of sperms. So ever since 1992, we've been doing ICSI, which is intracytoplasmic sperm injection, where we immobilize the sperm and place the sperm inside the cytoplasm of each egg. This is the gold standard, or this is the method of choice of fertilization when there is male infertility or in certain situations of female infertility. And we observe the development of the embryos for 5 days, at the max for 7 days. And then the embryos chosen, which is got based on which could have the maximum implantation rate, will be transferred into the uterus. And we transfer one, maximum 2 embryos as allowed by the law. And we can also do pre-implantation genetic testing, which by which we can select whether the embryos, aneuploidy can be selected, detected in the embryos. We can even screen the embryos for single gene disorders such as cystic fibrosis or Huntington's or BRCA1 and 2. Or we can also screen the embryos for any structural rearrangements in the embryo, in the chromosome of the embryos. We need to keep it safe, and we hope to make it affordable at some point of time, more so than now. But we have made it safe by understanding more about the biology, by using the drugs little differently, and by innovative strategic thinking, which started with the advent of cryopreservation, because at the advent of literally vitrification, I should be more specific, because the slow freezing was not that effective. So with the advent of vitrification, where we started, the process of freezing of the embryos became extremely efficient. It is about 99% efficient. So we started having fragmentation of the cycle. That way we have made our clinics OHSS free clinic. Otherwise, OHSS or ovarian hyperstimulation can be life-threatening. So we have made it quite OHSS free. And what all can we freeze? We can freeze the eggs, the sperms, embryos, testicular tissues. All these are not experimental. They're all clinical and being used on a daily basis in our clinic. Only the ovarian tissue, ovarian cortex is not that optimal that we can do. It's still good only in very specialized hands. And what is the cumulative success rate? Anywhere between the best of hands. In one stimulated cycle, it's about 40 to 50%, 45 to 46% to be exact. And the cumulative can be about 60+%. And it's directly proportional in the sense the success rate is inversely proportional to the age of the female partner. The more the age of the female partner, the lesser is the success rate. And as you all know, we are now governed by the ART bill, which was introduced in December 2021, and I'm sorry, in the Jan of 2021, and we all have to follow exactly by this. And the next important part of reproductive health is contraception. We need to have the fertility regulation, and it has to go in more so in terms of contraception. So contraception is a very important aspect of need for the family planning, which is very important for the health of the mother, basically. So it's quite an important thing in terms of to avoid teenage pregnancies, to avoid minor pregnancies, to avoid to have a gap between two pregnancies for the health of the mother to recuperate, and also to have the limited number of families, limit the size of the families to the tune of finances and everything. It is a very important aspect, and I think we can commend ourselves on the amount of contraceptive advice we have been able to give to our mothers to bring down the rate of the population as well. And coming to cancers, I think cancer is another very, very important aspect of reproductive health. One which we would be interested in is cervical cancer. In cervical cancer, I think we all know it is most commonly because of HPV virus, and the relationship between HPV and cervical cancer is very strong, and it is 10 to 20 times stronger than the relationship of cancer, lung cancer to cigarette smoking. And with the advent of the HPV vaccine, it is recommended that all girls must have this vaccine to prevent cervical cancer at a later stage in life. We can have at least one dose of it at the age of 9 to 14, or 2 to 3 doses when it given little later. And it has been, it is not that we should not give this vaccine later on in life. Yes, we can give, except that the efficiency is not as much as given prior to the first sexual intercourse. Definitely, the prevention is more important than cure in cancer care, more so in cervical cancer. And as we say, we should exercise, have a healthy life, reduce stress, eat healthy, and drink plenty of water. And that is exactly what we'll be looking at in terms of reproductive health. When it comes to, Sir did mention to me to highlight a little bit on the MTP Act as well. So I would like to mention that here. I did not go into the specifics of the ART law because I think that is something we can have on a discussion if you have any query on that. In terms of the MTP Act, which we have a lot of queries about, we have a lot of apprehension about. Even in the recent meeting that we had with the director of NHM and with the Secretary for Health and Family Welfare, the most of the queries from the private OB-GYN practitioners to them was from the MTP Act. So that is something I would like to bring about. While in 1860, where induced abortions were illegal, we have come to 1961. We have liberalized abortion services in India, by which we have saved millions and millions of women from unsafe abortions. We have decriminalized the abortion seeker and the medical practitioner who offers medical induced abortion services. We had an MTP Act, the rules and the regulation passed on by the Parliament, then the central government and the state government takes care of the regulations. So it determines under what conditions pregnancy can be terminated, who can terminate, and where it can be terminated, and how many people needs to be involved in it per termination as well. The risk, it can be terminated whenever there is a risk to the life of a pregnant woman, or it can cause a grave injury to her physical or mental health, or when there's a substantial risk to the child, unborn child, if the pregnancy is in a minor couple, or it was caused by rape, or in cases of failure of contraception, also in a married couple. It is also allowed at any point during the pregnancy if there is an immediate necessity to save the woman's life. Sex selection is not an indication for pregnancy termination in India, and sex determination is illegal in our country. When can it be done? Up to 12 weeks, one practitioner can do it, and from 12 to 20 weeks, two registered medical practitioner needs to be present needs to decide and do the MTP. You can also use medical methods, but whenever we do that, there must be a display of the certificate in your clinic, but it must be available in all public health services. In an emergency, any pregnancy can be terminated by an RMP, even in an unapproved place, but must inform the district CMO within a day. And who needs to consent? Only the pregnant woman needs to consent if she is above the age of 18. If she is less than 18, a guardian or a legal guardian must be there. Or in case the woman is mentally ill, the consent of a guardian is required. Any other additional record of age, if she is over 18, is not required. Only the opinion form must be filled with the reason for termination within 3 hours of the procedure. And the second RMP, if it is between 12 and 20, when there is an incomplete abortion or an inevitable abortion or a missed abortion or a blighted ovum, they do not come under the purview of MTP Act because they are obstetric complications. And a report must be sent to the CMO every month, and both surgical and medical methods used. For the ground for termination should only be stated only in the opinion form, and the opinion of the provider is adequate to certify the ground for providing the service. There was amendment which was brought about in 2021, which said that with the increase in the gestational age for terminating pregnancies in special situations, and with that, they increased the age between 20 and 24, where two OB-GYNs can opine and take decision to terminate a pregnancy between 20 and 24. After the gestational age of 24 weeks, the couple have to be referred, or the pregnant women have to be referred to the medical board, which consists of an OB-GYN, a pediatrician, and a radiologist, and only their decision has to be awaited for the same. So it is the amendment included these things. One is increase the age of the termination between 20 and 24 without the medical board, and after 24 with the medical board. And all these special categories were also included in it, including minors, mentally ill women, women with medical disabilities, women with pregnancy in humanitarian settings, survivors of sexual assault or rape or incest, or when there is a fetal malformation, or even when there is a change in the marital status of an ongoing pregnancy. Up to 20 weeks, one RMP can decide. After between 12 and up to 12 weeks, one RMP can decide between 12 and 20, 2 RMPs, and definitely 2 RMPs for 20 and 24. And after 24, as I've already told, the opinion of the medical board, the permission of the medical board must be sought. And what are the norms? For termination up to 9 weeks with medical records with an experience of just 3 months in OG hospital, or training with 10 cases of MTB by medical methods or by an RMP in approved place can also do it up to 9 weeks. So after 9 weeks, up to 12 weeks, anybody except the above can do. And between 12 and 20, except the first 3 months, the minimum quality must have assisted 25 cases and done 5 independently. Between 20 and 24, a PG with 1 year experience, a 6 months or OG. Beyond 24, it has to be referred to the medical board. In terms of condition of failure of contraceptive, for only married women was applicable before 2021. After 2021, the amendment brought about that even an unmarried woman who has had a contraceptive failure can also avail the services of MTP. And in terms of strengthening the privacy, it has been mentioned that the information should not be disclosed to anyone except under the authority of the law. So it should not be entered even in the case sheet. You just have to write in the opinion form and send it to the CMO. And the name and particulars of anyone seeking abortion must be kept confidential except to a person authorized under the law at any time being in the force. So these are the amendments as a summary brought about in 2021. Indication has been increased, has encompassed unmarried women also. Gestational age, 20 weeks for all indications, 24 weeks for it has been brought to 24 weeks for even rape survivors, and beyond 24 weeks for substantial fetal anomalies, which must be decided by the medical board. And there's been some changes in the medical practitioner who can do the termination, and in the breach of the women confidentiality, the fine has been increased, and with the imprisonment of 1 year for the medical practitioner who reveals or breaches the woman's confidentiality. As we say, the old habits have to go, such as having sedentary lifestyle, to not taking reproductive health, sexual health as part of reproductive health, or not having good, not having emphasis on the reproductive health of both male and female, or we have to have new habits encompassing all these to improve the reproductive health of both female and the males in our reproductive age, starting from adolescent to the reproductive age. Thank you very much for this opportunity. If there are any queries, I'd be more than happy. And I once again apologize for the break. It was just the disconnection of my line. Thank you so much.
Priya, there was a question on whether there is legal issues for infertility and in male and female.
Sorry, ma'am.
There was a question in the chat box about
Yes,
legal issues, if anything is there for infertility in male and female. I think maybe they're asking about are they can watch for divorce or something?
Applying for divorce.
Divorce. Right.
Sorry?
On grounds of infertility, can the couple apply for divorce?
I'm not sure about that, ma'am, actually.
I just checked online, and I gathered the information like that is not the reason
for okay.
Maybe
maybe
the male is not able to satisfy a female, and they harass the female like that for so many months or years. On that basis, maybe the female counterpart
or if the female is not allowing intercourse, both can be basis for divorce. But as such, if they are
infertility
or endometriotic and they're not able to have a baby, or I don't think that is a basis for a divorce.
Maybe on a mutual consent, they can go for
I think it's best to go with mutual consent then.
Yeah.
Madam, on the same way, legal issues of converting male into third gender, is there any law to prevent or to stop? I think we really pity them, the way in which it is. Survival is a problem for them. Is there any legal issue?
I don't think there is any legal issue, sir, for somebody to convert, if they want to do conversion.
Can you stop it? Can you stop it?
But as long as, sir, I don't think there is any law, sir, but then as long as if you're in a marriage and you need to convert, I think then it might be a problem. I think they need to have a consent or something. I'm not sure if there is a law, sir, but they cannot.
In India, I don't think so, but I think Trump has been trying to execute that law there in US.
There it's rampant, but I think there are conversions here.
You would very much.
There are conversions here as well, but not as much as in the US, but slightly it seems to be, I'm hearing a little bit more about it right now, but there are conversions happening, but I think it's best that they think about it and do it before they get married, or if they are, they be open and divorce and allow at least the partner to get out of the marriage so they can have a life themselves.
Sir, any more questions?
Madam, I just already asked regarding the reproductive health and solar energy or ozone, impact of the environmental factor on reproductive health. Solar and ozone.
Okay, sir, we are not very sure. We don't have much of studies on solar or ozone in reproductive health, but we do know other factors in the environment that can affect reproductive health, such as EDC and all other chemicals which are very commonly seen in the environment or in the food that we eat and everything right now. But in terms of ozone or solar, we are not sure about that. We don't have any studies to prove it or disprove it.
It's more of free radicals, right?
We don't know, ma'am.
No, generally I'm saying. Okay.
Last question, madam, regarding the white people and black people, black race. The black race has more reproductive health than the whiter people. Is it true or false?
Sir, actually, it's a reverse. When we do IVF, this is what has been found, sir. The genetic factor, the race that we belong to, has got some effect on the pregnancy rate when we do IVF. One of the better ones are the Caucasians, actually. The Africans don't have that great success rate when it comes to IVF. The next would be us Indians. And then the better ones are the Caucasians, actually.
Thank you, madam. Well done, madam. Thank you.
Thank you, sir.
Dr. Jairam, sir?
If there are no questions, we can conclude, madam. You can give some take-home tips, Sujata ma'am.
Yeah, so very well done, Priya. It was very insightful and valid points. I feel like about the suicidal rate which you told and about the teenage pregnancies. I think as part of IMA, we have to concentrate and more enlighten and create awareness programs on this aspect. And one more thing, there is so much of inequality in gaining the medical help because of the socioeconomic status of the girls or as such any people that should be addressed to. And we should try to avoid teenage pregnancies. That is what I think it hit me when you talked about teenage pregnancies in Dharmaburi. It's on the rise. So more of awareness on contraceptive methods and more into the avoiding teenage marriages and taking medical help on to avoid sexually transmitted infections. All that awareness we should have more awareness talks and in the, in the media and things like that. That's what I feel, and it was very well done. Thank you.
Thank you, ma'am. Thank you, ma'am. It is not just in Dharmaburi, ma'am. It is everywhere. It is just that Dharmaburi has got the highest. That's all.
No, that was
Yes,
like, we know
it did
things,
hit
but,
me. I mean, you will not believe, when I was running the genetic clinic in RSRM, we would have so many couples, these girls less than 20, 17, 18s or 19 coming with recurrent pregnancy loss. In that project, I had a few of them, which was shocking, literally.
Yeah.
Well, it's not a simple medical problem alone, madam. I think social problem.
It's a social thing, sir. Rightly said. It's a social thing, sir. It's a mindset thing also.
Exactly. There's a lot of cultural change which is happening.
Yes.
Yes. We in our day-to-day, our clinic, we see a lot of unmarried pregnancies and things like that.
Yes.
Do you agree?
Yes, ma'am. Yes, ma'am. Yeah, they don't come to us because we don't offer those services. But then we do see, and the age of female attaining menarche is also reduced. Yeah. So they're, it's by the age of 10, they start menstruating. So it's by the age of 14 or something, they all start having relationships. So it's quite a mindset thing.
Quite common nowadays. Not in the Western culture, more so in India, even in South India, things are happening. Yeah, as parents, we are also more into it, and we have to create awareness in each family should do it to take it in a wider sense. First, the family should take part. The parents should be aware of it and impart that knowledge in the kids.
Sure. Yes.
Jayaraman sir, thank you. Jayaraman sir, thank you very much.
Thank you. Yeah. Thank you, Professor Sundarmurthy sir, my teacher. Thank you very much. So we had a wonderful talk on the sexual and reproduction health awareness talk by Dr. Priya Kannan madam. Wonderful, crisp and clarity. Wow, awesome. Sujata ma'am told புலிக்கு பிறந்தது பூனை ஆகுமா அப்படின்ட்டாங்க. அது சான்ஸே இல்ல. பயங்கர மேடம் வந்து ஒரு 10 புலிக்கு ஈக்குவல் அவங்க. சூப்பரா பண்ணீங்க. Awesome talk madam. We all enjoyed. Lot of take-home messages. And also you touched upon the MTP rules and all. So this is the need of the hour. We are facing a lot of issues with the physicians and other thing and all. Why you did this, that, did, and a lot of queries, a lot of inquiries going on. It's a need of the hour talk, very, very important. And wonderful moderation by our Rotarian Dr. Sujata Gajendran madam. Awesome, really lot of tips and take-home messages. Thank you, Sujata ma'am, and thank you, Priya Kannan madam, for the wonderful session. And the first talk also very nice, colorectal cancer update. I thank the Vijay for the wonderful, slow, crisp, and superb talk with the case and all. And the moderator, Suresh, very nice. I thank you all the delegates, more than nearing 200 delegates. They have listened our talk. This is the very, very useful thing. And our leaders, I thank you, our IMA AMS leaders and the national leaders took part actively, felicitating all our encouraging these things. So IMA is one of the platform to create a lot of awareness about all the departments. So thank you all for this wonderful evening. So long live IMA. Thank you. We'll see again next month with a very good different topic. So thank you very much. Have a nice day. Thank you. God bless you. Bye. Thank you. See you.
Thank you, sir. Thank you, sir.
Thank you so
Good
much.
evening to you.